you this question, what would your answer be? I'm excited and eager to treat a patient with stiff fingers. I would say most of us would say no, that we are not excited. It is difficult, challenging, and often frustrating. What would you say if I said the stiffer the joint, the more you need to push or the less you need to push? It seems logical that we need to push more the stiffer the joint. But I hope that you leave this presentation understanding the reasoning for pushing less. What about passive range of motion of stiff fingers? Do we believe it creates an immediate but long-term improvement? Or is it that it looks fabulous in the clinic, but the patient usually returns with the same level of stiffness? That is indeed my experience, and I assume it is yours as well. So what is the meaning of the word stiff? We can say that we're scared stiff, or we can be for creating stiff peaks in the egg whites, or we can have a stiff drink, or we can keep a stiff upper lip, or we can be a stiff, or we can be so cold that we're frozen stiff, or we can even be bored stiff. But we usually use the word stiff to describe joint movement. In a search in the Journal of Hand Therapy on the term stiffness, we find 400 articles demonstrating that stiffness is a frequent and common problem for hand therapists. So let's look at stiffness. The dictionary term means difficult to bend or rigid. One would describe an I-beam as stiff because of its material and its shape. We use the term stiff to describe a lack of joint movement. But in reality, the stiffness we see in the hand describes the inability of structures to move in relationship to one another, which is not the dictionary definition of stiffness. In my career, understanding and treating stiffness has been like a big puzzle. I've worked to put additional pieces of the puzzle together. Some are securely in place for me. Some seem to be going into place, but there's still some pieces of the puzzle missing because none of us have the absolute and accurate approach to alleviating stiffness. Let's think of injury and how it begins a cascade of events that creates healing, but also can create stiffness. The injury occurs, and there is a natural tissue response to this injury. This is the response that creates healing, although one of the first stages is edema. But there is also often an element of immobilization. And when I use the word immobilization throughout this presentation, I do not just mean external immobilization, where we apply a cast or a orthosis, but I also mean, if you will, internal immobilization, where there's co-contraction of the muscles and the patient is protecting the joint from movement. It's, if you will, it is a self-imposed immobilization. It can actually be a restriction of motion or limitation of motion, and therefore it's a partial immobilization. So this occurs also in response to injury, but this immobilization, in addition to influencing the tissue response, also creates a cortical response. We respond in our motor cortex to the way we are moving. We are able to influence and control both the tissue response and the cortical response by beginning early motion. The motion changes both of these responses, and we end up with a return to normal motion. This is the ideal, and as hand therapists, we're fortunate to be able to participate in this model frequently. But what happens if early motion does not always begin or is not successful? The patient then develops a maladapted pattern of motion, a way of moving that is unable to incorporate full range of joint motion, and unfortunately that reinforces the continued maladapted pattern. So if there is a maladapted pattern of motion, secondary to the inability to fully move is the presence of a chronic edema that may also have elements of fibrosis with it. When motion is not full, the lymphatic pumping cannot be normal, and therefore the chronic edema is maintained. When we examine these joints with limited motion, we are able to discern that there is a hard in-feel to any passive range of motion. The joint moves as far as it will go, it stops, and there is resistance to continued passive motion. Most of all, when we see a patient who has developed this maladapted pattern, it seems that regardless of the treatment approach, that there is limited or no progress in regaining motion. It's as if the patient is stuck in a vicious circle and it's very difficult to break out. Peacock, who did a significant amount of study on stiffness, described interarticular stiffness as a fixation of the tissue layers. In other words, they're stuck together. The movement between these layers of tissue, which is the normal movement, is simply not possible. This results from a basic change in the physical properties of collagen tissue in response to injury and immobilization. Injury and immobilization influences the new collagen that is healing any injury or wound, and it also influences the natural cross-linking of collagen that occurs in response to stimuli. So injury and immobilization allows both types of collagen formation to occur and therefore contributes to stiffness. We have all seen patients with significant stiffness in the fingers who had a wrist fracture but had no direct trauma to the hand. This results from the limited motion or immobilization of the fingers, whereas the wrist stiffness results from the new disorganized collagen which is healing the trauma. Early after injury, we see a pattern of stiffness that is an interrelationship between edema being present, limited motion being available because of internal or external immobilization, and the beginning of some joint stiffness and tissue adherence, and that limits motion, which then allows the edema to remain, which contributes to immobilization, which contributes to more adherence. But our experience is that with influence to any one of these factors early on, and the introduction of motion, that this vicious cycle can be broken through and all three factors are then diminished. Early motion directed towards soft tissue is intended to provide movement that is enough to regain glide of the differential layers without disrupting the healing wound. We use the same early motion with tendons to create movement, which will prevent adherence, but that is not enough movement to create rupture. And with fractures, we again create movement for differential tissue glide, but not enough movement that it will create instability of a healing fracture. But when joint stiffness has become chronic and has been present for a longer period of time, we now see an interrelationship of the factors that create stiffness that is much more difficult to influence. There is joint stiffness with extensive soft tissue adherence and a pattern of motion that does not reinforce joint movement, and that pattern is influencing the motor cortex. At the same time, the chronic edema and fibrosis is not being remediated because of the inability to move. No longer can we use our typical treatment approaches and be successful in breaking through this vicious cycle. To break this vicious cycle, there needs to be a coordinated, simultaneous approach toward all three problems. When stiffness becomes chronic and we examine the patient with gentle passive range of motion, we're able to identify a hard and abrupt end feel to that passive motion. Human nature tells us that it's stiff, it's hard, it's resistive, so we need to push in order to reduce this stiffness and create the potential for active motion. But this is one of our traditions with the early stiffness, which works very well, which, as we can demonstrate, no longer works when there's chronic stiffness present. If we ask a patient with stiffness to actively mobilize the stiffness, what we observe is a range of motion that is unproductive without blocking. Here's the perfect example of a patient who, instead of stabilizing the wrist in extension to be able to transmit more power into finger flexion, loses that ability and flexes the wrist instead of the fingers. Therefore, active range of motion in a stiff hand such as this is unproductive without some means of blocking and transferring motion to the stiff fingers. In addition, passive range of motion may indeed gain passive motion in the interphalangeal joints of the fingers, but we observe this to be a temporary response, and there's great difficulty in the patient maintaining the mobilization that is gained passively in the clinic. Here is an example of an open dislocation of a PIP joint with very limited motion in both extension and flexion. The local change in the tissue has brought about a mechanical change. There is increased resistance at the PIP joint. But that mechanical change has created a cortical change. In other words, the patient begins to identify finger flexion and extension as being movement at the metacarpal phalangeal joint rather than at the interphalangeal joint. So the mechanical and the cortical change become interrelated, such that if we approach this in our treatment only with a mechanical approach, we no longer are able to be effective in creating true sustained change.